Hello team, this video is just for a select few of you that I haven't been able to meet up with, mostly use status or point threes. I just want to go over this conscious sedation audit information to help us be compliant. So I'm going to do the best I can over video, and then I'll try to reach you as I can. If you have questions, please email me. Or I am in the office right now Tuesday and Thursday and Friday. So any of those times I will be available. I will just dive right in. So basically this video, something in my eye, is being made because we need to achieve regulatory compliance for conscious sedation in our ER. Everybody has seen this sheet. This is Michelle's handy dandy conscious sedation audit form, and it mostly delineates everything that needs to be done in the chart in order to maintain compliance. But I do know that in the moment it's a lot to read and be checking, especially if you're doing a sedation for, a screaming kid or a flailing old lady, something along those lines. So I have been working with Michelle. She created this document. It is laminated and it is in the sedation folder with the audit forms. It can be wiped and used at any station that you are doing sedation at, and it's basically just a checklist of the same thing to help us make sure we're getting all of our regulatory buttons clicked. And then I also, for the sake of triple redundancy, made a badge buddy. They are also in the sedation folder. If you would like one, you can go get them. They're in there. And hopefully that's another tool to help make us successful. And then lastly, I've been working with Michelle, Chris, and IT to get a taskbar added to the narrator for regulatory compliance. So basically the goal should be that we're 100% compliant all the time, and that we have all sorts of fail safes to make sure that that is happening. I'm going to address one more thing before I get on to the audit. Minimal sedation should occur maybe like 2% of the time. If that does occur, it's legitimate. It is not charted as a sedation. It's just anxiolysis, or it can be for pain. One example would be like a child with a very obvious fracture, and the parents don't really want to put them under. They just want it to be a quick pop just back in. And so, you give a little bit of Versed, or you give a little bit of ketamine, but it's not to alter them, it's to calm them down. So you can do that effectively. Another example would be like an elderly woman that, has dislocated a shoulder, and you really don't want to put her too far under. All you want to do is make her just a little bit comfortable, and pop that thing back in real fast. So the goal would not be to change their level of consciousness, but to just change their pain or their anxiety level to accommodate the nursing care or medical care that we need to provide. So if you have any questions on that, let me know. That you can do with any provider. That can be a mid-level or a doctor. So this is just a printout of the Joint Commission audit that we follow to audit the charts to make sure we are compliant. I'm just going to go through each of them. There's 20 of them. About 5 of them are just provider specific. I'm going to go through the nursing ones, and then you'll just kind of know what we're looking for, what we're looking at, maybe fill in some gaps of education or knowledge of what regulatory requires, and then you can reach out with questions. So the main few points there in the pre-procedure checklist that we have to hit for regulatory is we have to have documented if there was a consent form signed, what the ASA score was, and then what the intended level of sedation was. it's pretty much always conscious sedation or moderate. Again, anxiolysis, we don't need to use the sedation narrator, and we don't do deep sedation in the ED. So then another thing that we need to have done prior to medications being given is we need a timeout documented as well. And then within 2 minutes of when we give that sedation med, let's just say I'm giving ketamine at 1900. That means that within 2 minutes of 1900, I need to have documented a full set of vitals, including a telestrip and tidal CO2. They just need to be on both of those monitors. And then we need an LOC on file as well. So a lot of what I see in the audit so far is like on a child, an 18-month-old, they're thrashing around. It's impossible to get a blood pressure before we actually sedate them. And so it's just not getting done or documented. And what needs to happen is if we can't actually get a vital sign like a blood pressure on an 18-month-old prior to, just put in the comment box like unable to obtain due to patient restlessness, or a monitor unable to read due to patient agitation, whatever. As long as you have documented somewhere that you attempted and why it failed, then you're covered. So yeah, I hope I didn't say all that too fast, but basically within 2 minutes of giving your sedation med, you need an LOC and a full set of vitals, or the reason why you were unable to obtain certain ones of the vitals. Another thing is after you have given your sedation med, let's say we gave the ketamine at 1900, you need to do Q5-minute checks for 15 minutes. So that would be, 1905, 1910, 1915. If for some reason at 1905 the doctor says, I don't think this is enough ketamine, the kid's not really out enough, I'm not comfortable, go ahead and give them another dose. You need to put somewhere why you're redosing. So when you go to give the ketamine again in the MAR, there's a comment section. You can just say per MD given for patient restlessness, or level of consciousness unchanged, additional support needed. And that will tell us why we gave more. And then from the time you gave that med, your Q5-minute checks start again for 15 minutes for vital signs. I hope that makes sense. And then just to kind of layer on top of that, every 15 minutes times 2, or at the 15-minute mark and the 30-minute mark, you need a level of consciousness, a pain, and a full set of vitals documented before you can be done or consider the patient recovered. So I hope that makes sense. If you have to give a reversal med, you need to keep that patient for at least 2 hours before you let them out of the ED. That's just house-wide policy. They have to be monitored for that duration of time. Looking at my notes, sorry. Don't want to miss anything. We talked about that. Oh, and not only do I can't remember if I said this, pregnancy brain, sorry everybody. At the 15 and the 30-minute mark, you need the vital signs, LOC, and pain. So you've done Q5 checks times 15, and at that 15-minute mark, you need the LOC, pain with the vitals, and then at a 30-minute mark, you need vital signs, LOC, and pain. Sorry if I said that twice. And then last two things are we have had Crystal put in the Epic firing, I don't even know what to call it, where it auto fires if the doctor orders a sedation med of any kind in the MAR or in the AVS, it will auto populate sedation education now, but it's always important, just call out somewhere when they're leaving, maybe in your note or in the discharge section. Just call out that you educated them, and then it's imperative that we're putting that they went home with a responsible driver, because it's a violation if they do not go home with a responsible driver. So I hope that that was clear and that you learned something maybe you didn't know before. Those are the basic requirements to remain compliant with regulatory, to help us provide optimal and safe patient care, and then also to be able to operate as a facility. So if you have any questions, feel free to reach out. I hope that this video finds you well and that you're having a great day. Thanks, guys.